Hi everyone, my name is Sahdev Baweja. Welcome to the Sign Ask the Neurologist podcast series. Today we have the pleasure of interviewing Dr. Fawaz Al-Mufti. He's the Associate Dean of GME Research, as well as the Associate Chair of Neurology. Dr. Al-Mufti, thank you so much for joining us today.
Thank you so much, Sahdev, for having me. It's a true pleasure.
So for our first question, could you tell us about your journey to becoming a physician and specifically a neurologist?
Yeah, of course. It started a long time ago. So I graduated from medical school in 2002. Just to give you some background about like my upbringing, I actually grew up in Europe. I was born in Iraq. I grew up in Europe, and we traveled all over Europe. I ended up getting the bulk of my education in Cyprus and in the United Kingdom, and ultimately my family decided to move back to Iraq, which is where I completed high school and ultimately got into medical school. Ended up graduating from medical school in 2002, a year before the Iraq War, like the military operations in Iraq, and I don't think anything could have prepared us for what was to happen. I've always been fascinated with the brain, but I'm not gonna lie, like neurology was not like a top of my priority list as far as like things I'm going to like a career I'm going to embark on, especially when you're training in a war zone. By no choice of mine, I ended up training in emergency medicine. Due to again working in a war zone, you find yourself like needing to learn how to triage patients constantly. So when 2003 happened, I had already done some like general surgery rotations, pediatrics, OBGYN, internal medicine rotations, and then the war happened, and we were literally just like plunged into like utter chaos. And as frustrating and scary as it was, but I found myself as the chief resident for a almost like 900 bed hospital in Baghdad, Iraq. Probably one of the largest hospitals in the country, if not maybe even the second largest in the Middle East. Like a massive hospital, and while all the attendings disappeared, we were left with like essentially a group of I think like 7 or 8 residents, very junior doctors, essentially running a massive hospital with little to no resources. So working through the war, I always, again, like I said, I was always passionate about neurology, but it was a luxury. I could like going into a field that I was passionate about was a luxury I just couldn't afford. So as a PGY2 resident, I was essentially running one of the largest health systems in the country, in the middle of a war zone. So I'm talking about the logistics of like learning how the pharmacy operates, to triaging the emergency department, to figuring out how to make sure that the generator has enough gas to essentially fuel an elevator. It was a truly a humbling experience. I learned an incredible amount in a very short period of time. Almost half of us gave up. They were like, yeah, we can't do this. Like, we got into medicine, yes, but we cannot. This is just too much for us. So some of us basically took on the task of they found some weapons and stood outside to essentially guard the hospital so we can focus on helping the patients. And others basically decided to care for the patients to the best of our ability. We became the surgeon, the obstetrician, the pediatrician, the internal medicine doctor, and the emergency doctor, like all at once. And we had to treat like people dealing with from labor to essentially brain surgery, like anything and everything you dealt with. Humbling experience. I learned a ton, like I said, and there was essentially, again, this was like a time just before everybody had phones where you could text your parents. I had no phone. I had my parents thought I was dead. By the time I actually got back, it was like 3 months later. A lot of the bridges were essentially like disconnected; they were bombarded, so you couldn't actually cross from one side of Baghdad to the other because like there's a river that crosses through it, the Tigris River. So yeah, it was a I don't know. I don't think that was the introduction you were expecting, Sahdev, right? But that's you asked me how like my early career, and that's basically what happened. Ultimately, I like after assuring my parents that I was alive 3 months later, I completed training in emergency medicine, and ultimately ended up doing joining Doctors Without Borders. And with MSF, Médecins Sans Frontières, I traveled like to many countries. I traveled the world. Uh, Probably I can probably put money on the fact that like if you name a war zone, I've probably been there at some point, even if it was brief. But ultimately, I met my wife and we decided to like she got pregnant. We decided to move to the United States. So when I moved here, they were like, "Yeah, you kind of need to do your training all over again." And I wasn't naive. I mean, I knew I probably had to do some training. I took my USMLEs, but I didn't expect them to make me do my residency again. So when some of my colleagues who I worked with MSF and Doctors Without Borders, they were like, "Hey, Fawaz, join us. You can do emergency medicine." I was like, "There's no way. I'm like, life's too short to do the same thing over and over again. If I'm going to do my training again, I might as well learn something new." I've always been passionate about the brain, so I ended up doing neurology, and I've never looked back. It's been an absolute thrill. I've enjoyed every single moment of it.
Thank you for sharing. I know yours is probably one of the uniquest journeys I've heard so far, but it's definitely great to hear. And I think it definitely, you learn a lot from it. So I'm glad you were able to share that with us. Um, was there anything other specialty you were considering besides neurology?
Um, you know, Part of why I chose neurology was because I felt like, in addition to the fact that I felt like I didn't know enough about it, and I wanted to learn more about something, and I wanted to dedicate time to like mastering an organ I knew very little about. Um, I did consider other specialties, like other like some surgical specialties. I considered emergency medicine just because, probably because I felt like it was so easy. It just came easy to me. Um, but like in hindsight, I think I was destined to go into neurology. Um, Going into neurology, when I interviewed, I actually interviewed like pretty broadly across the country. And I I remember looking through like my list, and like I probably interviewed in like almost every single quarter of the country, from like all the way from California to Seattle to like Florida to like New York in the Northeast. Um, and I fell in love with an area that probably felt the least like home, which was like Long Island. I'll never forget the view of the Long Island Sound on the top floor of the State University of New York at Stony Brook like tower, looking out, and I was like, this is exactly where like I felt like I was probably burned out, and that's part of the reason why I chose a place that is so serene and so calm. I absolutely fell in love with the place. I will say, like within 6 months of doing my neurology rotation, I felt like I was like, it just I realized that neurology, the way it was being practiced was like I felt like I was gravitating towards the acute care neurology, like acute care portion of neurology, and ended up realizing very early on that I wanted to do neurocritical care, which was almost like the perfect marriage between emergency medicine and neurology. Um, so probably within like 6 months to a first year, I ended up uh, focusing my application and focusing my like planning my next phase of my journey. And I decided to go into it was going to be either stroke or neurocritical care. That's basically how I embarked on the second limb of my journey.
You sort of mentioned how you transitioned to neurocritical care. Could you tell us about what conditions and what patients you see now as a practicing physician?
Yeah, yeah, of course. So, within neurocritical care, you end up treating patients in like probably you treat the sickest of the sick. That's basically what you end up treating, and those primarily with like acute neurologic conditions. Um, and that can range from like acute ischemic stroke, including patients with ischemic stroke, hemorrhagic stroke, like intracranial hemorrhages, patients with subarachnoid hemorrhage, patients with subdural hematomas, epidural hematomas, status epilepticus, patients with like acute myasthenic crisis, patients with Guillain-Barré. In a way, neurocritical care is very much general neurology. Like what we historically think of general neurology, only the acute care portion of general neurology. So I love it because I still deal with like epilepsy. I still manage patients with epilepsy. I still manage patients with neuromuscular disorders. I still manage patients with like strokes. But I'm focused on the acute care portion of it.
Thank you. So I know you're an incredibly busy person doing a bunch of things, both as your time being a physician, but also helping med students like myself get involved in research and other things. So what would you say is like a typical week in your life or day in your life?
Yeah. No, that's a great question. So basically a typical month, let's say a typical month is divided into, I do a week of neurocritical care where I'm on like Monday to Sunday evening, or like to probably Monday morning even. And I'm managing all my patients as the neurocritical care attending or the neurointensivist on service. I round every morning with my team, and and my team, which is comprised of like neurology residents, neurosurgery residents, my neurocritical care nurse practitioners, my pharmacists, my nutritionists, and my neurocritical care fellows. We round on all our patients. In addition to like, so I'll do that for a week. In addition to doing that, I actually also cover. So basically, after doing neurocritical care, I decided to I wanted to add a procedural element to my practice. So I ended up sub specializing in neuroendovascular or neurointerventional surgery, where you use microwires and microcatheters that you thread into the blood vessels, either through the wrist or through the groin, and you pass them into the blood vessels in the brain, and you're able to either secure a ruptured aneurysm or ruptured arteriovenous malformation, or you could remove a clot that's blocking blood flow to the brain. So I subspecialized in that. So currently, my work, like my typical schedule, will include approximately 10 days of neuroendovascular call, where I'm on call for like any emergent case, as well as like any elective case. So I can have a patient who comes in with like an elective, an incidentally identified large aneurysm that I want to treat. Historically, these are patients who were treated using neurosurgical techniques and open brain surgery, basically. Today, many of them are treated using minimally invasive neuroendovascular techniques using a cell linear approach. And I feel very fortunate because like this field has evolved so rapidly, and conditions that we would typically not have been able to treat using a minimally invasive approach maybe 10 years ago are now commonly treated endovascularly. So I'll do 10 days of that. So between neurocritical care and endovascular, I'm covering approximately 2 weeks, just under 2 weeks. When I'm done with my neurocritical care, my neuroendovascular rotations, I dedicate a lot of time to research.
Thank you. So what advice would you have for someone who wants to pursue neurology, potentially end up doing stuff that you're doing?
You know, I mean, my advice is, what what I'm currently doing is like probably like I could not envision like an alternate pathway for myself. Although this is a second career, like I feel extremely fortunate to have like practice and train under these circumstances, because you can't. There's no way you can essentially like uh, like in any way can I argue that my first career did not influence my second career. By the contrary, it was very much influenced by it. Um, my advice is to this is not like, I mean, like, you need to know that this is exactly what you want to do. Neurology as a specialty is probably one of the most fascinating, most exciting fields, I believe, because although I considered and ultimately subspecialized in neurocritical care, stroke, and neuroendovascular surgery, I could have been just as happy if I did movement disorders. Because now with what you're able to do with like neuromodulation, um, your neurosurgical colleague will deploy implant the electrode in the brain for like patients with Parkinson's disease. But then ultimately beyond that, everything else is up to you. You decide to control how to control that pacemaker and how to control which leads you're stimulating. And the impact you can have on your patients is incredible. And we can talk more about like the subspecialties of neurology, but if somebody's interested in doing what I'm doing, I would say it's extremely exciting. My advice is to try to engage in research as early as possible because it's become more and more competitive. And I personally have probably like mentored like close to 50 students. Some of them ended up going into neurology, others decided to go into other specialties. And I'm perfectly fine with that. Like ultimately, I'm happy to continue to proctor and mentor students, regardless of what specialty they go into. But it definitely is a competitive. It's become more and more competitive, and it's definitely, especially if you want to get into some of the more complex, more competitive subspecialties.
Thank you. And you kind of touched upon this, but where do you think the field of neurology is headed in the next 15, 20 years?
Yeah, no, that's a terrific question. Neurology today is kind of where cardiology was like 30 or 40 years ago. It's expanding ever so rapidly. What we're able to do today is nothing compared to where we were like 10 years ago, not even 5 years ago. When you look at what we've been able to do with like a disease like multiple sclerosis, we had like a handful of medications when I was in residency. We currently have like more than 20 medications. Multiple sclerosis was a debilitating disease, and today it's very much a chronic disorder. Not to say that, like, not to belittle the disease, but we have a lot of disease modifying therapies that can keep the disease at bay and prevent these patients from falling into like from one exacerbation to another. So many subspecialties have opened up, and we've all become extremely subspecialized. So in a way, we've become in a way, it's become a field where, although we're subspecialized, but that's not necessarily a bad thing. You can go into neurology and not know exactly what you're going into, but know that you will find an area that within neurology that's going to make you very happy at the end of the day. And from day one, you are the consultant's consultant. Everybody's consulting you because a lot of people don't, like, let's face it, a lot of people are not experts in the brain, and you are the expert on the brain. So what ends up happening is, like if say you decide that you want to go into an area like you don't want to go into anything that's like really intense. Headache medicine or headache neurology is a beautiful area that you can actually have a very meaningful impact on a lot of these patients who are struggling with these headaches. Patients who have, if ultimately you want to go into cognitive or behavioral neurology, that's also a very beautiful area, very rapidly evolving area that today, like within the past like 2 months, we now have a new medication that you can potentially consider for patients with like early onset or like early stages of dementia. neurophysiology, where you treat patients with epilepsy, is like you can have a massive impact on the quality of life, like of your patients. If you want to give, if you want to feel a little bit more like a hero, you want to give TPA and see the reversal of like the neurologic deficits, you can definitely do stroke neurology, and ultimately you'll be able to witness firsthand like the power of the medications that you're giving, and you can see those patients walk in with like hemiplegia and a very high NIH stroke scale, and ultimately like reverse their deficits so they're able to walk out of the hospital. Not saying that's what happens with every single patient, but it's extremely rewarding when you actually are able to be part of the team that's delivering that care. If you want to do like like some more procedures, placing central lines and doing bronchoscopies, and in some places even putting external ventricular drains, you can definitely do that, and you can go into neurocritical care. Yeah, during training, I learned how to do tracheostomies. We were able to do bronchoscopies. You're able to do a lot of stuff, a lot of procedures that are, it's like, again, neurology is not historically seen as a procedural specialty, but there are definitely areas where you can like do a lot of procedures. An area like neuroendovascular is always, like, again, it's very near and dear to my heart. It's extremely, I'm very passionate about it. And I think the future of neurology is probably in endovascular, where now we have these stentrodes that are being deployed in the brain, in the superior sagittal sinus, that are connected to these pacemakers that are able to read brain waves. And ultimately, over the course of a period of time, we'll be able to translate that into signals that it can actually understand, comprehend, process, and execute. So you can connect that to an exoskeleton, and you can control, with the power of your brain, just thinking about it, you can control an exoskeleton. In patients with like end stage, like ALS, for example, where they're quadriplegic, you're able to control a computer. And with the computer, you're able to essentially type a complete email. This is not like I know it sounds like an episode of Black Mirror, but believe me when I tell you, it's real. It's happening. There's a randomized controlled trial called the COMMAND trial that is actively enrolling patients. Don't take my word for it. Just Google stentrode, and you will see that this is happening in New York State. And I envision that over the next like 5 years, we will be deploying these stentrodes in a lot of patients. And it's not to say that like people were not talking about this in the past, and neurosurgeons were deploying these grids over the brain connected to pacemakers. The problem with them in the past is they would all become scarred and with fibrotic tissue, and the signal becomes impeded. Now, when you're deploying them in a vein that has very little endothelial cells, endothelialization, your signal is not impaired. And if ultimately you don't want to, like, there are definitely risks associated with these procedures. If you want to help your patients, you still want an endovascular, like a larger, more procedures than you can do with neurocritical care, but not as high risk procedures as you could do with like neuroendovascular. You could do interventional pain, where you could do epidural injections, you could do nerve blocks, you could do trigger point injections. There's a lot that you can do.
Thank you. I think it's definitely exciting for those of us who are interested in neurology just to see the amount of potential that is there. For our last question, we'd like to ask this to everyone. What is your favorite part of the brain or central nervous system, and why?
I actually, my favorite part of the brain is the brainstem. The brainstem is like the command center of the body. It controls consciousness, it controls respiration, and it's also the highway, the main highway between the brain and the outside world. Everything from the brain going to the world goes through the brainstem. Everything from the outside, like from the world, comes to the brain through the brainstem. People talk about people like when even physicians talk about brain death, they don't realize they're actually talking about brainstem death. That's what brain death is. So because that's how important the brainstem is. And my favorite artery, you didn't ask, but my favorite artery is the basilar artery, because that is the only artery in the body that is actually formed by the fusion of two arteries. It's so important to us that we were born with a spare part. So just in case one vertebral artery gets occluded for whatever reason, you still have the other as a spare part. I always jokingly talk to my residents and my fellows about how this is probably the best example of evolution. At some point, when we were like hunting out in the wilderness, those of us who had like one vertebral artery and got injured, they probably died out. And the ones who actually survived, and we are probably the offsprings of those individuals, are the ones who actually had two vertebral arteries that had this anomaly that where the two verts fused to form the basilar artery. So that's my favorite artery. My favorite cell is actually the Purkinje cell. But again, you didn't ask that. That's all right.
Thank you so much, Dr.
My pleasure.
We really appreciate you taking the time out. I know you're incredibly busy, and we're also really grateful that you're at NYMC and helping mentor so many students like myself. So thank you so much.
My pleasure. My pleasure. Sahdev, thank you so much for having me. It was a true pleasure and an honor. And please, this is an open invitation to you and anybody interested in neurology, neurosurgery, psychiatry, honestly, any subspecialty. If you're interested in research, please reach out to me. I'm happy to help.
Thank you.